It is my pleasure to introduce our next speaker, Dr. Jonathan Fluxman. Dr. Fluxman retired just before the pandemic after 25 years as a family doctor working in a deprived part of inner city London. He returned to the NHS for a year after the onset of the pandemic. He has studied and written about airborne transmission and the impact of the virus on working class and racially diverse communities in the United Kingdom. He is the COVID lead for Doctors in Unite and a member of the COVID Pledge campaign in the United Kingdom. Dr. Fluxman, the floor is yours. Thank you.
Thank you very much, Kevin. And I thank you for inviting me to speak. It's a real pleasure to be here. And I'm in fact very pleased to be able to talk to people in the US because we all know that this is an international problem and that, it's a global pandemic, of course, but also the problems we face in getting governments and employers and big business to actually put in the protections we need are pretty much the same wherever we are across the globe. So I think the way forward is definitely to share our experiences and our work together in going forward. Okay, so Kevin's told you about me. I will go ahead and share my screen now. So I'm going to talk about quite a few aspects of COVID, actually, and forgive the artistic license from the title of the talk. I will say something about the UK public inquiry because I know quite a few people in the US have been interested in it. It's one of the few state-level inquiries, state being country level, that are going on in the world at the moment. I'm sure there will be others to follow, and I know people have been following it. So what I'm going to do is just rattle through some basics with COVID. Forgive me if you know what I'm talking about, particularly in the first and second bits. It's probably old hat to you, but I find that it's useful just to go over the basics, at least in a brief form, so that we can set the scene to go forward. If anyone wants to get in touch with me, my email address is here, and I'm very happy to share the slides if anybody wants to make use of them. Okay, so this is an airborne disease, anatomy of the lung. Again, I'm sure you're familiar with. So breathe the virus in, it goes into the lungs, and these are the little alveoli where gas exchange takes place, oxygen in and carbon dioxide out, with a capillary around each alveolus where gas exchange takes place. And that's where the virus penetrates through. And this is a rather busy slide, but essentially what happens is the virus comes down, being breathed in into these little lung sacs. They cause damage to the wall of the sac and also the capillary wall of the tiny blood vessel that runs just adjacent to the alveolus. So you get leakage of fluid and red blood cells and so on into the air sac, and fluid goes in, and you get virus, and all sorts of biochemical reactions are triggered by that, causing a local inflammatory response. But the key pathology here is a thrombotic one, as you can see, and that is important to bear in mind. It's not really a respiratory virus, in other words, causing damage to the lung tissue itself, although it does do that, of course. So SARS is a bit of a misnomer for this virus. So again, you may know this: big, small, medium, and small blood vessels, capillaries, are where most of the damage happens. And every tissue in the body has a capillary bed like this, where you have the tissue and the blood coming in through the arteriole and going out through the venule, delivering oxygen and nutrients and taking away carbon dioxide and waste material. And you get this vasculitis happening in all those tiny capillaries. So that's a normal one. And that's one that's been infected with COVID, and you get clumping of platelets and red cells and fibrin in the clotting cascade, and all of these chemicals and proteins and things are triggered, and you get blockage of those tiny little blood vessels, and that's bad news. And it can happen anywhere and everywhere. So in all tissues of the body, okay? I won't go into all the details of all of them, but just to make the point that this virus can and does get into almost every tissue in the body. And here, for example, is a slide of the cerebrospinal fluid from a couple of kids who were symptomatic, and they found the virus in the CSF of the children. And remember when we were told it doesn't affect kids, and if kids get infected, it's mild, and they don't get any problems. Well, hey ho, they're no different from adults, although they do get it less severely in the main. So just to emphasize the effects on the cardiovascular system, in the heart in particular, on the left you have a diagram or an actual model of all the heart muscle which has been dissolved away, leaving the coronary circulation with all the capillaries in the heart. And if you get those little clots in all the capillaries, an extensive area in the heart, you can imagine that if the muscle is being starved of oxygen and nutrients, it can die, it can work much less efficiently, so you tend to get cardiac failure. If you get blockage of larger vessels, then you get ischemia and myocardial infarction, i.e. a heart attack. So depending on where the clotting takes place, you get different clinical presentations. And then looking more broadly at the cardiovascular system, we've spoken about the heart, but if you get clots in big blood vessels, they go back up to the heart, through the heart into the lungs, where you get pulmonary embolus, which is a clot in the vasculature of the lungs. If a thrombus goes up into the brain, you get a stroke. And you can get lots of tiny little emboli going into the lung tissue itself, and then you get so-called adult respiratory distress syndrome. So you can see from the pathology, the pathophysiology, why COVID is such a multivariate disease in terms of its presentation and indeed of long COVID. And we'll come on to long COVID in a bit. The other important, or one of the other important pathophysiologies of this virus is the immune dysregulation. It can cause both increased immune function and diminished or decreased immune function. And there's a whole range of abnormalities that it causes. There was some controversy early on, and in fact, until quite recently, where some researchers were arguing for this. A.J. Leonardi in particular, people who know the references in the work may know who I'm talking about, and you get a lot of stick from the doubters and the naysayers, but it's quite clear now that the immune function is impacted significantly. And, for example, this is a dendritic cell, which is part of the immune system, and its job is to take messages to the main defenses of the immune system and say, there's a problem, there's a foreign virus invading us, and you need to come quickly and kill it off. Now, those cells are damaged and killed off by the virus, so the whole kind of warning system of the immune system can be damaged. And as I was saying, you can get overactivity of the immune system, so you can get increased cases of autoimmune diseases like rheumatoid arthritis, and you can get reduced function, so responses to other infectious diseases, for example. And people will remember streptococcal infections in children in particular. And there was all kinds of bending over backwards to avoid saying the word COVID by the naysayers and the minimizers. Everything from adenovirus and people with dogs, would you believe? But the immune dysfunction is real, and I think an important part of the pathology. The other important bit that's perhaps not so well known and not emphasized that much is viral persistence, and this quite clearly does take place. And there's a very good researcher in the US called Amy Prohl who's done quite a lot of work on this. And the work shows that it can occur, I mean, it's a busy slide, sorry about that, but it can occur in just about any tissue in the body. And this particular study published in Nature shows evidence of live virus and fragments in many, many tissues. And of course, that can trigger ongoing immune stimulation. And viral persistence is important for new mutations, which can come from the sheer magnitude of infections, the billions and billions of infections and replications taking place, but also viral persistence, particularly in immunocompromised patients who can't get rid of the virus. And that is a favorable environment for new variants to emerge. So other clinical manifestations, RSV in kids, this should read leading cause of death from infectious diseases in children, not overall death. But things like diabetes, 1 in 20 new cases of diabetes is down to the virus. And all kinds of things like erectile dysfunction in pregnancy, preeclampsia, etc., etc. So, we could talk for a very long time about all the manifestations of the disease. It can basically get anywhere. So in terms of outcomes, this is quite a useful breakdown. You get the acute illness, everything from being asymptomatic to getting very sick, going into ICU and actually dying from it, although that's a lot less common these days than in the early days of the pandemic. Chronic illness, including long COVID, organ damage, and indeed excess deaths from related problems. And we'll talk about that in a bit. And here are the main sort of pathophysiological mechanisms for doing that. There's a lot of talk. It's died down a bit now, but again, the gaslighters and minimizers were very fond of saying last year, particularly here in the UK, that, COVID is now no worse than the flu. In fact, flu is worse. And of course, that's absolute nonsense. This is a graph of the numbers of cases of flu versus coronavirus or SARS-CoV-2. Here's with the start of the pandemic. What's interesting here is not so much the difference in the pathologies, but the fact there was no influenza all over the world, really, in the winter, or the Northern Hemisphere, in the winter of 2020 to 2021. And the CDC's got a good explanation at this link about why. And basically because we were taking mitigations. And it showed that airborne mitigations will get rid of flu as well as other airborne pathogens. And this whole argument that we don't need to worry about COVID because it's less harmful than flu downgrades the importance of influenza. Flu kills tens of thousands of people every year in our countries. I think it's wrong that they're saying that it's like the flu. It's not. It's much worse in many respects. But flu itself is dangerous. So let's mitigate against all airborne viruses rather than comparing one with another and saying, well, therefore we don't need to have any mitigations. It's a completely upside down logic as far as I'm concerned. Symptoms of acute COVID. I had my third bout about a month ago, and my symptoms were pretty much this here, very sore throat actually, and nasty headache and so on. And luckily I've made, I think, hopefully, a full recovery from it. But it was quite unpleasant for the first sort of 3-4 days. And I was testing positive till day 11. We'll come back to infectivity periods after infection in a bit. Long COVID, I don't want to spend a great deal of time on it, but obviously it's very important. And here are sort of some of the main symptoms, again, very, very varied, but these are the main ones. POTS is important, postural orthostatic tachycardia syndrome. And there's actually quite good symptomatic treatment for it. And I suspect that in the US you have the same kind of problems that we do, in that the condition is not yet mainstream in terms of being recognized, and indeed, more importantly, resources being put into place for proper treatment, for research, and proper treatment protocols and guidelines being put into place. So we get a lot of graded exercise therapy approaches like, you just need to push yourself a bit and get out there and do stuff. And of course, that's completely the wrong thing to do. And I like this picture, which I took from this very interesting economist I heard her talk and grabbed one of her slides. Deaths and hospitalizations are the tip of the iceberg we can see, and the massive iceberg of long COVID underneath. And this is a slide showing that it's a bit old now, it's over a year old with the data, but a big chunk of people with COVID have quite serious symptoms, serious in terms of impacting their lives. And unfortunately, recovery from long COVID is not great. People do recover, but the majority of people don't and have ongoing symptoms for a long time. And the overall numbers, certainly here in the UK, are slowly increasing. This is a slide which shows the number of infections, or the number of times you need to get infected, and your risk of getting long COVID, depending on which figure you accept for the risk per infection. The CDC some time ago estimated a 20% risk. So after 5 infections, we got almost a 70% chance of getting long COVID. The actual number, I don't know, it depends who you believe. Personally, I think it's between about 5 and 10%. So it's a bit lower. But the problem is, of course, There are no mitigations in place, and we keep getting reinfected. So we're all on a curve somewhere. Even if you're on this lowest curve, you know, after 20 infections, you've got a 20% chance of getting long COVID. I don't want long COVID. I want to be protected from this virus. And this is a slide showing that here in the UK, we've got sizable numbers of children with long COVID. And there was a study here called the clock study that showed a 12% risk of long COVID in kids from infection 1 and a 16% on reinfection. And, you know, interestingly, a 4.5% risk with no infection. So there are obviously a crossover and the importance of having control groups in these studies. Anyone can get long COVID. I particularly like showing this. This is a long COVID support group for endurance athletes, which is a Facebook group here in the UK. They've got 1,800 members. It's gone up 400 people in the last year. And these are really fit people. These are people who will cycle 30 miles to and from work or run a sort of 3-quarter marathon at the weekend. They're really fit people, and their numbers are going up. So anyone who says, I'm fit and healthy, I can't get long COVID, not true. And this is quite helpful here on the left to show who's most at risk. It's interesting. Men are more at risk of the complications of acute infection, but women certainly twice the risk of men and 4 times the risk of children of getting long COVID. Tends to be younger, middle-aged women in the main, health and social care workers, teaching and education, and also transport. And the usual suspects, poverty, overcrowding, and poor working conditions contribute, as well as obesity and pre-existing conditions. Organ damage can happen outside of the framework of long COVID. There's a study that showed at 5 months, lung, brain, and kidney changes were evident on MRI scanning in people that were hospitalized for COVID. So this disease is nasty. This virus is nasty. Excess deaths, I mentioned before. This is cardiovascular deaths here in the UK. We had 100,000 excess deaths from cardiovascular disease up to June 2023, since the beginning of the pandemic. And here in the UK, there's an argument because the baseline, you know, excess deaths are measured against the 5-year moving average. So we're now in year 5 of the pandemic. So deaths from the pandemic are starting to be included in the baseline. So they will hide the excess deaths. So fortunately, people are onto this little ruse that the authorities are trying to use to pull the wool over our eyes and are plotting, you know, pre-pandemic expected deaths against the actual figures. Right, transmission. And this is a sort of centerpiece of what I want to talk to you about. You'll all know it's airborne. Forget about fomite and contact transmission for all intents and purposes. Yes, there's a theoretical risk, but, you know, people like Juan Luis Jimenez basically discounted altogether. And I agree entirely with that. But in terms of airborne spread, it's important to remember that it's not just the one-to-one spread here. You know, it's group spread and so-called super spreading. Okay. Droplets, as I say, you can more or less discount. So it's very important to keep this model in place. And, you know, particular thanks to Prof. Lindsay Ma, who is one of the rock stars of the pandemic, as I like to call these guys, you know, without whose work we would not know anything like what we do. And she's been fantastic. And I'm sure you're all familiar with her work. But as I say, important to realize that super spreading is driving this thing. It's not one-to-one spread. And I'll show you some graphics which show this quite nicely. This is an early study that was done in India of nearly 600,000 people, an epidemiological study that showed that 5% of infected individuals accounted for about 80% of cases, and 70% of people did not pass the infection on to anybody else. So there's a small number of individuals who account for most cases. Now, either they are super spreading individuals that produce huge amounts of the virus themselves, which can happen, or it's because of where they are. And I think that is the crux. This is another US study, a modeling study that showed pretty similar things. And we submitted evidence to module 1 of our inquiry about super spreading and airborne transmission. So it's not one-to-one spread like this, these linear chains. It's these cluster phenomena that cause spreading. So you've got one person infecting 10, 12, 15 other people, like cluster bombs, those awful weapons that some military still use. And it's a much, much better explanation of the exponential spread of pandemics. This mathematically just does not compute in terms of exponential spread. And that's just another paper showing this, and that our mental picture should be that this cluster, one person infecting lots of other people, and then people from that cluster going on to infect lots of other people in other congregate settings. I'll show you a few of the famous epidemiological studies, which again you may be familiar with. This is the call center in Seoul, which 44% of people were infected within a few days of each other. And this absolutely classic graph of lots of patients being infected within a few days. And you can just look at that and say, it's inconceivable that everybody working in one workplace could come in having caught it at the same time and be found in one workplace. It's obviously what's happened is one or two people, here are the index cases, who've infected lots of people in that call center because they share the same air, obviously. This is a well-known outbreak here in the UK in a sandwich factory. And here's the shop floor. And we have that classic graph again. And we had over 300 workers got infected. And of course, the employer blamed the workers. Backed up, I should say, by the public health doctor in the area, shamefully. And they blamed them for sharing motor vehicles and not socially distancing and so on and so forth. But of course, they shared the same air. We don't have information about the ventilation in the factory, unfortunately, but it's the only thing that could have explained this massive outbreak in that very short space of time. This is a study in Italy of schools outbreaks, that same cluster pattern. A very pretty picture here and a very good epidemiological study done in South Korea. When these are schools, that's the Taekwondo class and the language class and the daycare center. And you can see one index case affecting all of these people, and then it spreads out from there again. A nice, massive US study here, which showed 70% of households, the index case were children bringing it home from school. So this business of people getting infected in the community and bringing it into schools and workplaces is completely wrong. I really like this diagram. This wasn't SARS-CoV-2. This was a MERS virus in South Korea. Very pretty picture. And this was in hospitals. And obviously, as medics, we're particularly interested in that. This index case was a chap who spent, I think, over 24 hours in an emergency department. And he infected, I think, over 80 people, both healthcare workers and patients, and about 15 of them died. And this is what coronaviruses can do in crowded, busy emergency rooms in any country in the world, really. So as I say, when people say, oh, you tell your boss or the school or the gym or something, I got infected in your premises. No, you got in the community. It's almost certainly not true. And, congregate spaces are where transmission happens in the main. Of course, there's an enormous amount of one-to-one and one-to-two spread in households and so on in terms of overall numbers. But when we talk about what's driving transmission, it's these super spreading events that occur. So I want to spend a minute talking about our esteemed former health minister, Matt Hancock, who you may have heard of. In 2020, he said all COVID workplaces are secure. And this was a time where government was trying to tell people it's fine to go back to work after all the lockdowns and so on. And I just did a Google search on the 3 months before that and came up with 15 workplaces with over 1,600 cases at the time he said that. And then at our COVID inquiry in December last year, he admitted that in the early summer of 2020, right? This was after 3-4 months of the beginning of the pandemic. They said they knew that aerosol transmission was more important than droplets. What did they do in terms of guidance for workplaces, for hospitals, for schools and so on? Did they change them from the droplet wash your hands stuff No, they didn't. They kept them as they are, and they've remained like that ever since, even though they admit that they knew it was airborne. Just to mention to Professor Lydia Moravska, another giant in the field who's been amazing in terms of giving us the information about airborne transmission of viruses. The repeated nature of infections is very important. We've all been infected at least twice, 3 times, and other people many, many more times. And here are some graphs of what's been going on here in the UK, especially in children. Children are getting infected most often. And the dangers of reinfection, this is the famous Ziad Al-Ali paper of the number of infections and the rising risk of hospitalization and organ damage. Time in a space is very important in terms of risk, the number of people, what are people doing? Are they talking, shouting, exercising, the ventilation in the space, and is there any air filtration and masking going on? Remember, prevalence is important. So if there's lots of COVID around in the community, your risk of getting infected anywhere is much higher than if there's very little. But again, shared spaces are the danger ones. Airborne protections work. Ventilation works really well, and this is this famous Italy school study that works, as do filters. 2/3 of transmission, according to Prof. Jimenez, can be eliminated by air filtration without any other mitigations in place. So very important. And of course, decent masking. This is a study here in the UK which showed that FFP3s are your kind of N95s, N99s, and these are surgical face masks. This is ICU, and this is A&E departments and so on. And this red bar here are housekeeping staff, not clinical staff. So it goes to show that all healthcare workers, be they clinical or non-clinical, are at high risk. This virus is airborne, it gets everywhere. And Black and Asian staff had the highest rates of infection of all. I just want to show that the great and the good in society are very good at telling us you don't need mitigations. This is a nothing burger, this virus, but they're very careful to look after themselves. This is Tedros, head of WHO, with an air cleaner at Davos. There's Tedros and Mike Ryan about to tell us that it's not airborne, it's droplets. And there's David Nabarro telling us here in the UK 18 months ago that this is a droplet spread disease, when in 2020, May, WHO headquarters had just installed a new ventilation system for their senior personnel. So very careful to look after themselves while telling the rest of us there's nothing to worry about. And there's President Biden on his visit to a high school in Montgomery, in Maryland. All of this gear was installed before he came. This was inside the hall. And when he went away again, it was all taken away with him. There are lots of things happening, and spaces are becoming safer all over the world, bit by bit, but it's still a real struggle, and we've got a long way to go. I won't go into the detail, but if you want to look at it, the slides are available. It's a race and class issue, as always with infectious diseases, and indeed most diseases. People of color are more affected, and the poorer you are, the more affected you are. And the disparities are very striking. So Black and Asian essential workers in the UK have 8 times the risk of white, so-called non-essential management and so on. Our infection control guidance is junk, absolute rubbish. It's completely unscientific. And we have a huge battle on our hands to get it changed. They just absolutely refuse to change it. There are no protections in hospitals. I mentioned about the infectivity period after a clinical infection. It's at least 8 days, and probably 10 is safer. That's my view of our guidance and the purposes to which it can be put. Hospital-acquired infection, not surprisingly, 30%. This was a while ago now. And on a mental health ward, this was a colleague here in a London hospital. Their figures at one point, but 2/3 of patients with COVID in hospital were infected in hospital. I'll just finish with some information about the inquiry. It's ongoing. Here are the modules. If you do want to look at more of it, here's the link to the official website. I think this is going to be a very important module. We've had modules 1 and 2. In fact, many of them are running in parallel. But this is the big one where we're going to hopefully get some accountability from the people that have made policy on our infection control guidance and why they downgraded COVID from a high consequence infectious disease to not being one. Surprise, surprise. At the same time that they found they didn't have enough N95 respirator masks, and they could thereby change the guidance to say that they just needed surgical masks in hospitals. And these are just some of my own conclusions about what went wrong. There was a lot of press attention to the individual behavior of our politicians, and I'm sure you heard about Boris Johnson and his mates who were partying and swearing at each other in the most disgraceful way. But the greatest failings were not that. It was a lack of protections in workplaces, schools, and hospitals, the privatization of the response, and the individualizing of it. So it was everybody's individual responsibility rather than a community approach, and that business and government and employers were supposed to keep us safe. We're going to have an interim report in next month, which will be interesting to see what it said, and we'll see whether this judge actually has teeth and is going to actually say something back to government. But personally, I don't hold out great hope, because all so-called independent inquiries very, very rarely challenge the ruling class in our countries and allow them to escape, although sometimes they do. Sorry, and lastly, to finish, get out there and campaign. We've been trying to do some of this. There's some pictures of our friends and colleagues demonstrating and some leaflets that we've produced. There's lots of information on our COVID Pledge website about campaigning within healthcare for safer healthcare. Here's a protest we held outside a very well-known hospital, and a banner we said about our infection control guidance. And, we've produced lots of leaflets and things like that, which can show things quite graphically and quite well to kind of educate and inform the public about the fact that mitigations work, and it's important that we do protect ourselves. And then lastly, we're having a conference at the end of September. You'd be very welcome to come along. It will be UK based, but as I said at the beginning, our problems are common, and be interesting and helpful to hear from you guys as well. Okay, I will stop there. Thanks very much.